So, good afternoon to all. So, we are going to learn about the borderline personality today, the majorly the nursing management, how to deal with these patients, and how the patient's behavior can be reshaped, the borderline personality disorder. So, first of all, we have to understand what is the personality, what is personality, and what is the difference between personality disorder. So, by definition, personality is any person's collection of interrelated behavioral, cognitive, and emotional patterns that comprise a person's unique adjustment to the life. The interrelated patterns are relatively stable but can change over a long period of time. So the personality is interrelated behavior, what the behavior of the person, how he thinks, and how the cognitive process are acting, and the emotional pattern which the person is exhibiting is constitute the personality. Now look at the personality disorder. Personality disorder are the class of a mental disorders defined as an enduring pattern of inner experience and behavior that deviates markedly from the expectation of individual's culture. So there is an enduring pattern, there is a long-standing pattern of the behavior or experiences which deviates markedly what is expected, by what is expected by the individual in the culture of that individual, which is pervasive and inflexible. So it is not more or less changeable, it is inflexible, and it is long standing, has an onset in adolescence or early adulthood, and the things are started in the early childhood period or in early adulthood period, and this is stable over time and leads to distress or impairment in the life of the person. So this is the definition of DSM, fifth edition, American Psychiatric Association. Now, what are the other personality disorders are uh, conventionally classified, and what are those personality disorders are uh, divided into three clusters, and the clusters have a common theme. Like in cluster A, there is a odd and eccentric behavior. In cluster B, there is dramatic, emotional, and erratic pattern of behavior, and the cluster C is anxious or fearful. So in the cluster A, there is paranoid personality disorder, schizoid personality disorder, schizotypal personality disorder. In the dramatic, emotional, erratic pattern of cluster B, personalities are antisocial personality disorder, borderline personality disorder, histrionic personality disorder, narcissistic personality disorder. In anxious and fearful cluster, there is avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. So, out of these personality disorders, two personality disorders are more important, which are antisocial and borderline personality, because other personality disorder may not get uh, more or less not get admitted or hospitalized in the psychiatric establishments, and because of the uh, brief brief exacerbation of uh, some personality traits, the antisocial personality disorder may get admitted because of the antisocial behavior, and the borderline personality disorder because of their self-harming behavior, impulsive behavior, and hostile behavior. They may get admitted into the ward, and the nurses may came across these personalities, and they should know what are these and how to behave with them and how to deal with them to normalize their behavior. So first we start with borderline personality disorder. The characteristics of borderline personality disorders are there is marked instability in the interpersonal relationship, mood, and self-image. Their interpersonal relationship are not very much stable. There is instability in the personal relationship, and their mood is also fluctuating, and self-image is also there is a lack of self-esteem. Their images are self-images are distorted. They do not consider themselves as a separate image, or there may be derealization, depersonalization in their behavior. and the instability is significant to the extent that the individual seems to hover on the border between neurosis and psychosis. So when the brief period of intense behavior is there, then these seems like to be psychosis, and otherwise their behavior are look like at neurotic behavior. So this is considered as the border between the neurosis and psychosis. Therefore, the term borderline personality disorder is kept for that. So, differentiation whether the behavior is neurotic or psychotic is a bit difficult. And previously, also, this disorder was considered as a depressive disorder, because the depressive disorder is more common in these borderline personality disorder because of the low self-esteem and distorted self-images. So, as per the ICD-10, the borderline personality disorder or unstable personality disorder are described as, so the personality disorder in which there is a marked tendency to act impulsively without consideration of the consequences. So there is impulsivity in their behavior, and together with the affective instability. Affective instability means the emotional instability. The ability to plan ahead may be minimal. They are not in the capacity to plan uh, in such a positive way, and outburst of intense anger may be often lead to violence or behavioral explosions. They are easily precipitated by impulsive acts, are criticized or thwarted by the others. So this impulsive act can be uh, surface very rapidly after they are being criticized or thwarted by the others. Two variants of this personality are specified, and both share this general theme of impulsiveness and lack of self-control. So we will look at the both variants. The first variant is impulsive type. The predominant characteristic are emotional instability and lack of impulse control. Outbursts of anger, violence, and threatening behavior are common, particularly in response of the criticism by the others. So what is there in the second? This is borderline type. Several characteristic of impulsive type may also be found in this borderline type, but the patient's own self-image, aims, and internal preferences are often unclear or disturbed, including sexual orientation. There are usually chronic feeling of emptiness. A liability to become involved in intense and unstable relationship may cause repeated emotional crisis and may be associated with excessive efforts to avoid abandonment. So they are not in the position to live alone. So they avoid being abandonment and to be left alone. And a series of suicidal threats or acts of self-harm may be there, although these may occur without obvious precipitants. There may be no external stimuli, and these kind of acts can be seen in the borderline personality disorder. So what about the theory behind this? There is biological theory and there is psychosocial theory. Biological theory is not so important to learn the behavior. So psychosocial theory is more important to understand the behavior which you will find in the borderline personality is more important. So one is the childhood trauma. So studies have shown that the child of borderline personality disorder are reared in the families with chaotic environment. Their families are not very much aligned with the societal norms. Risk factors including family environment characterized by in the studies are the trauma to the child, neglect of the child, or the and or separation of the one or both of the parents, exposure to sexual or physical abuse in the childhood, serious parenting psychopathology, and the parents are not also mentally healthy, may be found in this family, like substance abuse in the parent or one of the parents, and any other kind of personality disorder in the parents may lead to borderline personality disorder. This is the psychosocial theory as per the childhood trauma theory of the psychology. Further, 70% of borderline personality disorder patients reports a history of physical and sexual abuse by Gunderson in 2011. In some instances, these disorders has been linked to the post-traumatic stress disorders also. You can see that there is lots of trauma is reported, neglect is reported, there sexual and physical abuse is reported. So these abuses and trauma may be uh, linked to the post-traumatic stress disorder in the adulthood or in the later childhood, which may resurface as a consequence of the abuse. The second theory is theory of object relationship, and this theory has six phases. So we go through one by one each phases. What are these phases, and in which phase the problem arises with these borderline personalities? In phase one, there is birth to 1 month, and this is autistic phase, and you can say it is half waking, half sleeping state, and most of the infant spend time in waking state and sleeping state. The main goal is fulfillment of need for the survival and the comfort. The child only needs the food and the comfort. You can say they need milk and the lap of the mother. In phase two, type of psychic fusion of mother and child is occur. The child views the self as an extension of the parenting figure. So child uh, view himself herself as a satellite figure of the parent, not the totally detached figure from the parent. Although there is a developing awareness of external sources of need and fulfillment, this is the phase two, which is from 1 to 5 months. In phase three, 5 to 10 months, this is differentiation phase. The child is beginning to recognize that there is separateness between self and the parenting figure. So he or she started now thinking that I am not integral part of my mother or father. In phase 4, 10 to 16 months, it's a practicing phase. This phase is characterized by increased locomotor functioning and ability to explore the environment independently. And the sense of separateness of the self is increased. So now there is increase of the separateness. And separateness is not yet established, but there is an increase in the sense. Now this is the fifth phase, which is 16 to 24 months. It is considered as a rapprochement phase. And now focus more on this phase. What it says, awareness of separateness of self becomes acute. Now it is now intensified. This is frightening to the child who wants to regain some lost closeness but not return to the symbiosis. The child wants the mother. There is a need for the emotional refilling and to maintain feeling of security. So acute feeling of separateness is there, but at the same time, he is emotionally is attached to the mother and wants the closeness. And he want to regain some kind of symbiosis, closeness, but he is not able to achieve. In the phase 6 is 24 to 36 months. In this phase, a sense of separateness is established. Now the child consider himself herself as a separate entity, and separation anxiety is also resolved because of the temporarily or permanent absence of caregiver. And the caregiver obviously in most of the cases are parents, mother and father. Now what happens in borderline personality is the personality is said to be fixed in rapprochement phase. The fixation occurs when mother begins to feel threatened. Now the this is from the mother side. The mother started feeling threatened by the increasing autonomy of her child. So her child's autonomy and separateness is increasing, so mother becomes anxious and so withdraws her emotional support during those time, or she may instead reward clinging and dependent behavior. If she feels like that, so the clinging of behavior is rewarded by the mother, and the dependent behavior onto the mother is rewarded by the mother herself. So when this happens, so the child started to believe that to grow up and be independent is a bad child. So now the mother is started rewarding for clinging and dependent behavior. So child started thinking that growing independently is a bad child, and to stay immature and dependent is a good child. So mother rewards for the clinging. So the clinging which the child can be considered as good behavior, he thinks that to stay mature and independent is a good behavior. Mom withholds nurturing from bad child. He also thinks that the mother holds nurturing from bad child. So some kind of negative consequences may also be imposed by the mother unknowingly or unknowingly. Consequently, the child develops a deep fear of abandonment that persists into adulthood. That this behavior, uh, the sense of fear of abandonment is remain there in the adulthood. In addition, because object consistency is never achieved, the child continues to view object as a part, either good or bad. So objectivity and consistency is never achieved. So he started looking things in a good or bad way, plus or minus way, or as of the all or none phenomena. This is called splitting. Means at the same time, one thing may be of extreme priority, extremely good, and at the other point of time, the same thing or the same person is not up to the mark, not up, or may be a negative figure for the another point of time. So this is splitting. Symptomatology, what is found in these personalities is chronic depression, one may found, inability to be alone or being abandoned is there, clinging and distancing behavior, splitting behavior is there, manipulation is found in such persons, self-destructive behavior, impulsivity, feeling of unreality, difficulty controlling anger. So now we will see what are these phenomena and what is the psychodynamics behind all these features of this personality disorder. So chronic depression. So chronic depression or depression is so common in this patient that before inclusion of the borderline personality disorder in the diagnostic criteria, many of these patients were diagnosed as depression, as I have said earlier also. The depression is so common in these patients. They were primarily diagnosed as depressed, but actually they have a deviant personality. Depression occur in response to feeling of abandonment. So if they feel like they will be thrown out, they will be left out, they will be abandoned by mother in early childhood, the depression may ensue. It also may occur a result of biochemical alteration or as a complicated grieving process in response to childhood trauma. So if childhood trauma is there in the childhood period, this may be because of the complicated grieving which runs for a long time, and the conflict is not resolved and it remains there, and that because of that the depression may occur. Underlying the depression is a sense of rage that is sporadically turned inward on the self and externally on the environment. So this is the depression may be a kind of sense of rage. This is turned to inward means turn toward the self of the patient. The rage is increased, and that rage may result into the depressive phase. So seldom the individual aware of the true source of these feeling until well into the long-term therapy. And what can be done, we will discuss later for this chronic depression. Inability to be alone. There is a chronic fear of abandonment. Patient with the borderline personality disorder have little tolerance for being alone. They are not in the position to be remain alone. Some kind of person should be there whom they trust, and they are not in the position to leave them. They prefer a frantic search for companionship if they are alone. No matter how unsatisfactory to sitting with feeling of loneliness, emptiness, and boredom. So, inability to be alone is the feature of borderline personality disorder. Clinging and distancing. First, we discuss the clinging part. When the patient are clinging to another individual, they may exhibit a helpless, dependent, or even a childlike behavior. They over idealize a single individual with whom they want to spend all their time. So this is again a all in none phenomena kind of thing. uh, if the one person is they want to spend time with, they want only that person. So no other person can fulfill or replace that person. So this is a clinging behavior, yeah. And with whom they express a frequent need to talk, or from whom they seek constant reassurance about their thinking, feeling, and behavior. Acting out behavior, even self-mutilation, may result when they cannot be with this chosen individual. Okay, acting out behavior, throwing out the tantrums, and even they self-stimulate to get their attention. So attention-seeking behavior is also a part of this personality. Now, distancing behaviors are characterized by hostility, anger, and devaluation of other, arising from the feeling of discomfort with the closeness. Now, what happens is some person is close, so desperately they want those particular person in their closeness, in their vicinity, and another point of time they become hostile, angry, and angry towards the same person, and they want to devalue the other. So they want to distance themselves from those person. So distancing behavior also occur in response to separations, confrontation, and attempts to limit certain behavior. If there's some kind of check and balance you will imply on these patient, they may acquire a distancing kind of behavior. Devaluation of other is manifested by discrediting or undermining their strength and personal significance. So these are the features how they think, how they act, and what is there in their mind has to be considered while uh, dealing with these persons, either in the psychotherapies, counseling, or managed by the nurse in the ward. So these theories should be kept in the mind. Splitting. So splitting is a primitive ego defense mechanism that is common in people with borderline personality. It arises from their lack of achievement of object consistency. They have not yet think that they are separated from their parent figure. This is object consistency, and it manifested by inability to integrate and accept both positive and negative feelings. In their way, in their view, people include themselves in life situation are either all good or either all bad. They do not live in the gray area. So they will live in either in the white side or in the black side. So this is splitting. Manipulation. In their efforts to prevent the separation, they so desperately fear patient with this disorder become master of the manipulation. So they, in efforts to prevent separation, they don't want to get separated from their ideal figure or loved one, or from the one who they want a close relationship. They they manipulate their behavior in a such a manner that uh, that person won't get out from his life without his will, like that. Virtually any behavior becomes an acceptable means of achieving the desired result, relief from the separation anxiety. Okay, playing one individual against another is a common ploy and ally these fears of abandonment. So manipulation is one of the behavior these personalities exhibit. Self-destructive behavior. So all the things are interrelated to each other. So you will find the one or more kind of behavior as a same psychodynamics behind it. So those in that the one is self-destructive behavior. This is repetitive self-mutilative behavior such as cutting, scratching, and burning are classic manifestation of borderline personality disorder. Although these acts can be fatal accidentally, but most commonly they are manipulative gesture to get the attention or the things they wanted to do, or they want to want they want to. And these gestures are designed to elicit a rescue response from the significant others. So this is a kind of manipulative behavior, this is a kind of threatening behavior, this is a kind of behavior which draws the attention of others, or like this. Suicide attempts are not uncommon, often result from feeling of abandonment following separation from significant other. Suicidal attempt means the self-harming attempt with intent of die is also not uncommon because of the depression, maybe of the post-traumatic stress disorder, and maybe uh, they are not able to resolve the conflict, so they may also attempt the suicide. Impulsivity. Impulsivity is the behavior in which the person act without considering the consequence of this act in future. So they act impulsively. Individual with borderline personality disorder have poor impulse control based on the primary process functioning. Impulsive behavior associated with borderline personality disorder include, it may be substance abuse. Impulsively, they may get into the substance abuse, or they may later become dependent on that substance. Gambling is also impulsive. They do not think of the losing money, but they find some kind of pleasure by doing that. Promiscuity is also a impulsive behavior. Reckless driving they may found to be doing, and binging or purging kind of behavior. Feelings of unreality. Sometimes the transient episodes of extreme stress can precipitate periods of dissociation in the individual with the borderline personality. This means that they get dissociated from their real immediate world. So they may get dissociated because of the feeling of unreality of themselves. Rage reaction, this is already discussed. Difficulty controlling anger is also part of impulsive act. Now, what are the common nursing diagnosis and intervention? What we have learned till now, what is personality disorder, what kind of behavior they have, what kind of psychodynamics it have, and how they are interrelated to each other. So, what a nurse can do in such a situation. For example, the patient is in the ward, and you have to deal with these uh, persons. And one thing is risk for self mutilation and risk for self directed or other directed violence. Like this is violence towards self, or maybe towards other, maybe a problematic situation to deal with. So risk of self mutilation is defined as a risk for deliberate self injurious behavior causing tissue damage, as we have discussed, by cutting, by burning, or by bruising, with the intent of causing non fatal injury to attain the relief of tension. So why they do this? And you will find that the injury is more or less non fatal, not causing the death of the individual. And this may be to attain the relief of the tension which is developed in the mind of that person. So risk of self or other directed violence is defined as at risk for behavior in which an individual demonstrates that he or she can be physically, emotionally, and or sexually harmful to self or to the others. To deal with this behavior, short-term goals are: patient will seek out a staff member if feeling of harming self or to others. So this is first short-term goal, and the second goal is patient will not harm self and others. In long-term goal, what we will want is patient will not harm self and others again in the long term. So how to see and what to do in such a situation or such a kind of behavior of self-mutilation? Observe the patient's behavior frequently. Keep an eye on the patient, and do this through routine activities and interactions. Avoid appearing watchful and suspicious. Don't let them know that you are watching. And close observation is required so that intervention can occur if required to ensure patients and other safeties. Secure a verbal contact from patient that he/she will seek out a staff member when the urge of self-mutilation is experienced. So this should be taught to the patient that they should come out with these intensifying thoughts of self-mutilation. So discussing feeling of self-harm with a trusted individual provides some kind of relief to the patient, and a contract gets the subject out in the open and place some of the responsibility for his or her safety with the patient. An attitude of acceptance of patient as a worthwhile individual is conveyed. So the person may get to know that there is somebody to take care of. So the impulse of self mutilation may be dampened. If self mutilation occur, care for the patient's wound in a matter of fact manner. If the person has done something harm to himself herself, so address the wound in a manner that the wound is addressed in an emergency situation, and do not give positive reinforcement to this behavior by offering sympathy or additional attention. Do not give sympathy and additional attention, and this may enhance or increase the maladaptive behavior, and the repetition of this behavior is more in the future if you sympathize or give the attention to the patient for this act. Encourage the patient to talk about the feeling he or she was having just before this behavior. So know what is the actual thought process the person having in mind while doing such type of act, and this may be helpful in solving the problem of the patient, or to understand or to address this problem in your uh, counseling. Act as a role model for appropriate expression of angry feeling, and give positive reinforcement to the patient when attempts to confirm are made. Okay. So appreciation, positive reinforcement should be given when such a act are not being carried out. It is vital that the patient express angry feelings, because suicide and other self-destructive behavior are often viewed as a result of anger towards inward onto the self. Okay, already been discussed. Remove all dangerous objects from the patient's environment so that he or she may not purposefully or inadvertently use them to inflict harm to self or others. Patient safety is a nursing priority, so remove all the dangerous objects like if there is a rope, phenyl, stethoscope, or scalpel, and Caesar, and it, the things like which can be used for self-harm purpose. Try to redirect violent behavior with physical outlet. If the intense feeling of doing harm to self or other is increasing, that impulse can be redirected towards the physical outlets like exercising, jogging. Physical exercise is a safe and effective way of relieving pent-up tension. So this can also be done. Have sufficient staff available to indicate a show of strength. So if the person is violent, so sufficient number of staff should be there to show the strength that we are more in number, we can control you. If the situation goes beyond control, one can administer tranquilizing medication, which is ordered by the physician or the psychiatrist, is necessary. If it is necessary to obtain the order, then obtain the order by the doctor, or physician, or psychiatrist. So, outcome criteria for this self mutilation and self harming behavior would be: patient has not harmed self to others. Anxiety is maintained at the level in which the patient feels no need for aggression. Patient denies any ideas of self-harm. Patient verbalize community support system from which assistance may be requested when personal coping strategies are unsuccessful. So these should be the outcome criteria. So things are to be minimized for the long term, and if the things are there, the person should be able to contact the healthcare professional, mental health care professionals. Now the next is anxiety, which may be severe anxiety to the panic disorders. Anxiety is vague, uneasy feeling of discomfort or dread accompanied by an autonomic response, the source of a non-specific and unknown to the individual. A feeling of apprehension caused by the anticipation of danger. So anxiety is the part of these personality, and the possible etiology. What may be the cause of this anxiety? May be threat to self-concept, unmet needs of the person, extreme fear of the abandonment, unconscious conflict, which may be associated with fixation in earlier level of the development, maybe the possible etiology for the anxiety. Now, what are the short-term goals to deal with the anxieties? Patient will demonstrate use of relaxation techniques to maintain anxiety at manageable level. This is the short-term goal. The long-term goal is patient will be able to recognize events that precipitate anxiety and intervene to prevent disabling behavior. So, anxiety is it may be severe to panic, and the patient with borderline personality disorder often resort to cutting or other self-mutilating act in effort to relieve their intensified anxiety. Being able to feel pain or see blood is a reassurance of existence to the person. This may be seen as the person is existing in the world, and the self image is more clarified. If injury occurs, care for wound is matter of fact and manner without providing reinforcement, without providing sympathy and positive reinforcement. Lack of reinforcement may discourage the repetition of this behavior. During periods of panic anxiety, stay with the patient and provide reassurance of the safety and security. Orient patient to the reality of the situation, what the situation is there, and the patient may be unreal about himself or his surrounding. The patient can be oriented to the situation. Correct misinterpretation of the environment as expressed by the patient. If the patient misinterpret the environment in a different way, so you can confront and correct his point of view. So in such a manner, an anxiety can be managed. Encourage the patient to talk about true feelings. Help him or her recognize ownership of these feelings rather than projecting them onto the others. So patient should be taught that what kind of feeling you have, this is your own feelings, and these are not the feeling of others, or what you are projecting that as if these are the feeling of other person. Have the patient work toward achievement of object constancy. So patient may feel totally abandoned when nurse or therapist leaves at shift change or at end of the therapy session. So this object constancy uh, should be try to achieve by the patient. There may even be feeling that the therapist ceases to exist. So when the shift is changed, when the therapy session is over, the person may think there I'm not the my the thing which I need is not with me. It is totally not existent, or it has gone. So reassure them that we are here, and leaving a signed note or card with the patient for reassurance may help. And they can be reassurant. Then whenever you call in the duty time, I will be there. I will come to help you. It is extremely important for more than one nurse to develop a therapeutic relationship. So what the problem of these this personality is, they remain most of the time in the black and white area, and to to reduce that area from extreme to the gray area, so one or more nurse can develop the therapeutic relationship with the patient. So this object constancy can be increased. The feeling of object constancy is increased. Okay. So outcome criteria for this behavior will be: patient is able to verbalize events that precipitate anxiety and demonstrate techniques for its reduction. So the patient has to verbalize and to demonstrate the technique, what he will do in such situation. Patient manifests no symptom of depersonalization. Patient interprets the environment realistically. The next is complicated grieving. Complicated grieving, a disorder that occurs after death of a significant other or any other loss of significance to the individual, in which the experience of distress accompanying bereavement fails to follow normative expectation and manifest in the functional impairment. Means, if someone has lost his or her some loved one, so what happens in grieving, that for a certain period of time, for few days or few weeks, you are in the mourning period. So this is a normal grieving. So after some point of time, you normalize and you return to your normal life. But the in complicated grieving, the grieving process is prolonged, and it is complicated. So possible etiology for this complicated grieving may be maternal deprivation during rapprochement phase, which is internalized as a loss with fixation in anger stage of the grieving process. This is one of the psychological theory. Loss of self-esteem as a result of childhood trauma. So loss of self-esteem and maternal deprivation can lead to complicated grieving. The short-term and long-term goal for to handle this behavior is the patient will discuss the nurse or therapist the maladaptive pattern of expressing his or her anger. Long-term goal will be patient will be able to identify the true source of angry feeling, accept ownership of these feelings, and express them in a socially acceptable manner in an effort to satisfactorily progress through the grieving process. Yes, this will be the long-term goal. Let's see. Convey an accepting attitude that creates a not non-threatening environment for the patient to express feeling. ठीक है? Convey the message and accept your own attitude that the person express his feeling without any hitch or hurdle. Be honest and keep all the promises, you know, and these promises and will be realistic one, those you can keep with the patient. So unrealistic honest promises are avoided in such a situation. An acceptable attitude conveys the patient that you believe he or she is a worthwhile person, and trust will be enhanced. If the trust is enhanced, the therapy will be more positively will give the positive results. Identify the function that anger, frustration, and rage serve for the patient. So, what are those factors which leads to the patient in a such situation, which creates or cause the anger, cause the frustration, and cause the rage in the patient? So, identify those factors. Allow the patient to express these feelings with reasons. If the patient is angry, frustrated, he is having some kind of rage, so this feeling the patient has to be expressed with a reason, with a rational reason. Verbalization of feeling in a non-threatening environment may help the patient come to term with the unresolved issue. And the first thing is trust should be there between the two, the patient and the nurse. Encourage the patient to discharge pent-up anger through participation in physical activities like brisk walk, jogging, or other thing, as we have earlier discussed also. As anger is displaced onto the nurse or therapist, this situation may come across through in your dealing with such a patient. The anger may be displaced towards yourself also. So caution must be taken to guard against those negative effect of counter transferences. Means you will you are also a human being. You may have tendency to develop uh, a negative feeling towards the patient. So in situation, guard yourself against developing such and such feelings. So counter transference should not be there. These are very difficult patients who have a capacity for eliciting a whole array of negative feeling from the therapist. So, uh, these are the difficult patients to deal with. You have to be very cautious uh, regarding the patient's behavior and your behavior also. The existence of negative feeling by the nurse or therapist must be acknowledged, but they must not be allowed to interfere with the therapeutic process. You must not must acknowledge your feeling that I am developing this kind of negative feeling towards the patient, and then yourself calm down your mind and come to the level of neutrality and start again. Explain the behaviors associated with the normal grieving process. In complicated grieving, explaining the behavior which is found in the normal grieving process may help the patient recognize his or position in the process, and he or she may found that the grieving which I am having is a impaired kind of thing or different kind of thing that should not be there. Set limits on acting out behavior and explain consequence of uh, violation of those limits. You know, you can set the limits of acting out behavior, like for anger, for rage, for violent behavior. One can certainly set a limit and be supportive yet consistent and firm in caring for the patient. सपोर्टिव भी होना है और कंसिस्टेंट भी और फर्म भी रहना है. The outcome criteria for this behavior is patient is able to verbalize how anger and acting out behavior are associated with maladaptive grieving. Patient is able to discuss the original source of the anger and demonstrate socially acceptable ways of expressing the emotions. Impaired social interaction in borderline personality disorder. Insufficient or excessive quantity or ineffective quality of social exchange is called as impaired social interaction. Possible etiologies in borderline personality disorder may be fixation, rapprochement phase of the development, extreme fear of the abandonment and engulfment, lack of personal identity. These may be the factor for impaired social interaction. For this, short-term goal will be patient will discuss with nurse or therapist nurse or therapist behaviors that impede the development of satisfactory interpersonal relationships. By time of discharge from treatment, patient will interact appropriately with others in the therapy setting in both social and therapeutic activities. Okay, now what to do and how to handle and how to see. Encourage the patient to examine these behavior to recognize that they are occurring. Patient may be unaware of splitting or of clinging or of distancing pattern of interaction with others. Recognition must take place before change can occur. First, they have to get realized that the psychodynamics are going in such way. Help the patient understand that you will be available without reinforcing dependent behavior. So they have tendency to show the attention seeking behavior or the dependent behavior or the maladaptive behavior for the availability of the staff. So one can clearly say that if they are in the need they will be available. Give positive reinforcement for independent behavior. If something has done by the patient independently, you can give positive reinforcement. Rotate staff who work with the patient in order to patients developing dependence on particular staff member. Okay, this has been discussed earlier. So this is also a remedial part or remedial for this behavior. With the patient, explore feeling that relate to fear of abandonment and engulfment. Help patient understand that clinging and distancing behavior are engendered by these fears. So fear of abandonment and engulfment is engendered by the fear of this thing. Exploration of feeling with a trusted individual may help patient come to terms with unresolved issues. Help the patient understand how these behavior interfere with the satisfactory relationship. Patient may be unaware of how others perceive these behavior and why they are not acceptable. So they feel like they are always they are right and their behavior is justifiable and they are doing in it a right way. So they should be apprised that the social interaction impaired because of such a such kind of behavior of clinging, distancing, and manipulative behavior, and to see the world in a black and white mirror. Assist the patient to work toward achievement of object constancy. Be available without promoting dependency. Do not show yourself to the patient when the patient want to seek you, want to see you because of the dependent behavior. So outcome criteria for this behavior is patient is able to interact with others in both social and therapeutic activities in socially acceptable manner. Patient does not use splitting or clinging and distancing behavior in the relationship and is able to relate to use of these behavior to failure of past relationships. What next? The next is disturbed personal identity. Inability to maintain an integrated and complete perception of self is disturbed personal identity. The possible etiologies can be failure to complete task of separation, individuation at the stage of rapprochement, underdeveloped ego, unmet dependency needs, absence of rejection by parental gender role model. These all may result into the disturbed personal identity means identity of self, how they are looking towards themselves. The short-term goal, patient will describe characteristics that make him or her a unique individual. Long-term goal, patient will be able to distinguish own thoughts, feelings, behaviors, and image from those of the other as an initial step in the development of a healthy personal identity. So now, what is there and what to do and how to look? Help the patient recognize the reality of his or separateness. So apprise them that you are a separate entity, and you are not a part of any of the other individual, or you are not a satellite of a some main planet. Do not attempt to translate his or her own thoughts and feeling on into words. So do not attempt to translate whatever the patient is saying. Do not translate those words, those feeling into words, because of the blurred ego boundaries. The patient may believe you can read his or her mind. So the person may become guarded, they become suspicious towards yourself, towards you. Help the patient recognize separateness from nurse by clarifying which behavior and feeling belongs to whom. So it is also clear. If deemed appropriate, allow the patient to touch your hand or arm. So touch and physical presence provide reality for the patient and serve to strengthen weak ego boundaries. So this touch should be the sociocultural things are to be taken into account, whether and how much touch is and what kind of touch is allowed, and socially, and the acceptability of the person, how the person perceives your touch. Encourage the patient to discuss thoughts and feelings and help the patient recognize ownership of these feelings rather than projecting them onto the others in the environment. So verbalization of feeling in the non-threatening environment may help the patient come to terms with the unresolved issues. Okay. Confront statements that project the patient's feeling onto the others. Now, what happened is the patient started projecting his feeling onto the others or onto the environment. Now, this is the time to confront. Ask the patient to validate why he is saying like this. And validate means he has to justify or give some valid reason for such and such behavior. The expression of reasonable doubt as a therapeutic technique may be helpful. You may say like, I find that hard to believe. So not by totally denying his thought process, you can say in such a manner. If the problem is with gender identity, ask the patient to describe his or her perception of appropriate male and female behaviors. Provide information about the role behavior and the sex education if necessary. If it is necessary, if it is distressing to the patient, they can be referred for a uh, the therapy for the gender identity, the incongruence in the gender identity. Convey acceptance of the person regardless of preferred identity. Patient may require clarification of distorted ideas or misinformation. An attitude of acceptance reinforces the patient's feeling of the self-worth. So it should be dealt like that. Always call the patient by his her name. If the patient experiences feeling of depersonalization and derealization, orientation to environment and correction of misperception may be helpful. By by calling by calling his or her name, they will also uh, work towards the object constancy, their individuality. Work with the patient to clarify values, discuss beliefs, attitudes, feeling underlying his or behavior, and help the patient to identify those values that have been incorporated as his or own. And at this point, care must be taken by the nurse to avoid imposing his or own value system and his or own belief system. Yeah, if you are from some uh, religious community or some local community which believes in such as other kind of feeling they have, other kind of beliefs they have, and do not impose those feeling as a right or wrong onto the patient. Use of photographs of the patient may be helpful to establish or clarify ego boundaries. Photographs may help to increase the patient's awareness of self as a separate form of others. Alleviate anxiety by providing assurance to the patient that he or she will not be left alone. Use of touch is sometimes therapeutic, and again, the sociocultural aspect and the degree of trust with the patient should be taken care of in the mind. Now, what will be the outcome criteria for this behavior? Patient is able to distinguish between own thoughts and feeling and those of others. Patient claims ownership of those thoughts and feelings and does not use projection in relationships with others. Patient has clarified own feelings regarding sexual identity. So these are the goal for this behavior. Now comes the chronic low self-esteem. Low self-esteem means long-standing negative self-evaluation, feeling about self and self-capabilities. Possible etiologies may be lack of positive feedback from the family and society, unmet dependency needs by the person, retarded ego development, repeated negative feedback resulting in diminished self-worth. So repeated negative feedback always works in a negative direction for development of individual, any kind of individual, not only the borderline personality. Anyone who is excessively negatively uh, feeded is not come out to be a person who can adjust in the society well. Dysfunctional family system, fixation in earlier level of development, that is rapprochement phase, and childhood trauma may be a cause of chronic low self-esteem. So short-term goal and long-term goal for this low self-esteem will be the patient will discuss fear of failure with the nurse or therapist. Patient will verbalize things he or she likes about self. These are short-term goals. In long term, patient will exhibit increased feeling of self-worth as evidenced by verbal expression of positive aspect of self, past accomplishments and future prospects. Patient will exhibit increased feeling of self-worth by setting realistic goals and trying to reach them, thereby demonstrating a decrease in fear of failure. So these are the goals. Let's see what's next. Ensure the goals are realistic. Whatever goal you have set should be realistic, should not be unrealistic goal that cannot be achieved. It is important for the patient to achieve something, so plan for activities in which success is likely. So success increases the self-esteem. Convey unconditional positive regard for the patient. Promote understanding of your acceptance of him or her as a worthwhile human being. Acceptance by other increases the feeling of self-worth. So, in such a manner, you can act. Set limits on manipulative behavior, which we already have discussed. Minimize the negative feedback to the patient. Uh, Encourage independence in performance of personal responsibilities as well as in decision making related to the patient's self-care. So, if the person is independently doing his own daily chores, this may also increase the esteem, self-esteem. Help the patient increase level of self-awareness through critical examination of feeling, attitude, and behavior. So this is kind of a self-exploration in the presence of a trusted individual. Help the patient identify positive self attributes, what the positive things you have in your personality in your life, and discuss ways to effect change in these areas. So the lower self esteem can be overcome. Outcome criteria will be the patient verbalize positive aspect about life. Patient demonstrate the ability to make independent decision regarding management of self-care. Patient expresses some optimism and hope for the future. Patient sets realistic goals for the self and demonstrates willingness to reach them. This will be the outcome criteria for low self-esteem. And in the end, the recap of the borderline personality disorders are the features you will find in borderline personality disorders are chronic depression, inability to be alone, clinging and distancing behavior, splitting, manipulative behavior, self destructive behavior, impulsivity, feeling of unreality, feeling controlling, anger, and low self esteem. So, these are the behavior which we have to deal with in borderline personality disorder in a manner that the outcome should be positive, should be fruitful, and we can assimilate these persons in the society in a positive manner. Thank you for all for patient listening.